pure red cell aplasia, along with the thymoma and the diamond black fan anemia, um, where the pure red cell aplasia develops, and also it develops in the B19 viral infection.
Yeah. So that's very good. I'm very proud of you. Rest of you, I'm very disappointed. There are 40 people in the group chat. If you guys are not doing whatever I'm asking you to do, then what is the point of sitting in my UWorld sessions? When you don't have to listen what I'm telling you to do, then what is the point of coming in, being a ghost and throughout the session and then go? We are here, we are giving so much of time and energy to you guys without asking anything in return. These are not our USMLEs, and if you are not going to focus on that, then I'm very disappointed in you guys. Okay. So, okay, we'll start with the question. He So there's this 15-year-old boy. He comes to the office due to right arm numbness. He plays on his high school baseball team and has been intensively practicing his pitching for an upcoming game. Okay, he's had fluctuating tingling and numbness involving the right shoulder, arm, and hand. Okay, he also has recently developed a dull pain in the right little finger and hand. Okay, the symptoms worsen. The patient has no medical problems other than being told he has an extra rib. On examination, there is right-sided weakness of the intrinsic hand muscles. Which muscle do you think is involved in the patient's condition? What do you guys think the answer is?
It's
Scalene muscles.
align muscles
Okay, why do you think that?
because this is extra rib is flagging for the thoracic outlet syndrome, which
Very
is
good.
happened because impingement of the cervical plexus and also the subclavian artery between the scalene anterior and scalene medial
Okay,
muscles.
so we all agree with the answer B. And yes, so it was thoracic outlet syndrome. Does anybody else want to go over what thoracic outlet syndrome is? Guys, he already
Uh,
beautifully yeah.
yes, in the thoracic outlet syndrome, there is the lower trunk compression because
Mm.
the brachial plexus passes because of the cervical rib. Actually, it compresses the lower trunk of the brachial plexus that is made by the C8 to T1, and also it causes the compression of the lower trunk as well as the subclavian artery and the vein. So we feel the congestion over the neck because of the subclavian artery and the vein compression, and also because of the lower trunk compression. The tingling sensations goes into the hand, just um, like a lower trunk palsy, like clumsy palsy.
Exactly. So we know that because of the extra cervical rib, what's happening is that there is compression of the brachial plexus is occurring. And whenever a nerve problem is occurring, and that is why we're having the numbness and the tingling sensation. Whenever USMLE is asking you about numbness and tingling, you obviously mean that there is some vein involvement over there. Okay, thoracic outlet
Mhm.
syndrome. What I want you to remember from over here is that there is something called as a scalene triangle. We know that it is made up of anterior and the posterior scalene muscles. So if I kind of zoom into it, you will see that this is the anterior scalene, okay, and this is the posterior scalene, and it forms the scalene triangle. So wherever this pathology is occurring, it is occurring in between the anterior and the posterior scalene. That's collectively called as the scalene triangle. Okay. The other thing that I want you to remember from this is that what's that? Yes. So the brachial plexus is getting affected, and that brachial plexus is causing numbness, tingling, and weakness because of that. Okay, now I'm going to ask you, what do the other muscles do? What does subscapularis do?
Ex-
Abduction up to 15 degree.
Okay,
So, no,
very
no,
good.
no, no. Yeah,
It causes adduction.
Adduction, yes. Adduction, sorry. Subscapularis adduction.
Yes. And does it do
Teres-
internal rotation or external rotation?
Internal.
Very good. What what does triceps brachii do?
Full deflection of the elbow.
Extension of the elbow joint.
Very good. And what does the coracobrachialis do? Coracobrachialis? Anyone?
Flexion. Flexion of the elbow joint.
Very good. Yeah. So, kind of like a root memorization question. You need to remember what these muscles do, what nerve passes through them, and the function of those muscles. You don't need to remember the origin and insertion. They don't ask you that. But you kind of go through the muscles. I know it looks really hard to remember, but unfortunately, that is the case in USMLE. You have to memorize it. There is no other way. Okay. The second question we do. Okay. So there is this 37-year-old woman. She comes to the ED because of the vehicle collision. The patient has severe pain at the left hip with any movement. Examination shows that left lower extremity is adducted and internally rotated and appears shorter than the contralateral leg. So I haven't seen the X-ray. What do you think the diagnosis is?
Posterior hip
Posterior hip
dislocation.
dislocation, yeah.
What does posterior hip dislocation involve?
It
Sciatic
involves
nerve.
the sciatic nerve,
Optic
involvement of
nerve.
sciatic nerve.
Exactly. So we have not even seen the picture, but we've kind of figured it out what's happened. So if you see the picture over here, you will see that it's kind of pushed a little bit backwards. Okay, so that means that it's usually backwards and a little bit downwards if you guys see it. So we know that was a case of the posterior hip dislocation. Posterior hip dislocation involves the sciatic nerve. What happens in anterior hip dislocation?
femoral artery will be
Femoral
injured.
nerve and artery.
Exactly. So this was a case of the posterior. You see that it's it's kind of like a little bit backward and inferior. It's a little bit downwards. So if I zoom in the picture, you can see that it's a little bit downwards. Anterior dislocations would have been a little bit upwards and outwards. Okay. So that is the difference. Okay, I have an important question. What artery involves that causes the avascular necrosis of the head of the femur?
It will be the
Medial,
medial
circumflex.
circumflex.
Medial
medial
circumflex
circumflex
femoral
artery, medial circumflex femoral artery.
femoral artery.
Exactly. So that is why hip fractures cause a lot of bleeding. Why? Because but if the head of the femur it gets compromised, avascular necrosis occurs, and they cause a lot of bleeding. Hip fractures cause a lot of bleeding, and that is why you use pelvic binders in that to kind of help with the patient's bleedings until they consult the orthopedic department. So we saw that posterior hip dislocation are shortened and internally rotated. What if it would have been an anterior hip dislocation? Then what?
Abducted and externally rotated.
Yeah,
Exactly.
opposite abduction and external rotation. Opposite.
Very good. Where does the lateral femoral cutaneous nerve involve? What does it do? What symptom does it do?
Sensation on the lateral side of the thigh.
Have you heard of the syndrome called meralgia parasthetica?
Yes, this is happening in the
Yes.
people who is having obesity or
Exactly.
in pregnant ladies, and there will be paresthesia on the lateral side of the thigh.
Very good. So those people who are obese or who wear tight-fitted garments, this is the nerve that goes in this. That's called lateral femoral cutaneous nerve. The name is suggesting that it runs through the lateral portion of your thigh. Those who wear tight garments, who are obese, this nerve gets involved and it kind of has a loss of sensation in that area. Okay, superior gluteal artery. What does it involve? What is it?
Abduction of the thigh. It innervates the gluteus medium and minimus.
Yes.
Okay, very good. Why is not vulnerable? Why isn't it vulnerable in posterior dislocation?
Because it's high in the high.
Very good. So we kind of we went through all of it. We know that what's happening in this. Okay, then we can come to the next question. Okay, okay,
Excuse me, Dr. Maheen, can I say something?
yeah, sure.
Like yesterday, Dr. Ahmad said, asked us to do, these questions, and we did already from question 1 to question 16. If it's possible, let's start from 17, please.
Sure.
Thank you.
Does everybody agree with us?
Yeah, sounds good.
No,
Thank you.
Dr. Maheen, if you can go through it because you can explain better. Um, we want to revise it. If
Yes,
everyone agrees,
yes, Dr.
it's a
Maheen,
good revision.
we can revise with you
Revise it with you.
because we
No,
need some extra explanations. Yes.
Yeah,
it's a
if
quick revision, Miss Maheen, please.
yeah,
Yeah, sure.
I don't mind. It's not my step one that I'm preparing. I am comfortable with whatever you guys are, comfortable with. So, okay. See, the another thing comes of the osteonecrosis of the patient. Where do we see osteonecrosis? I want 5 causes now. Shoot.
Sickle cell disease,
Very good.
glucocorticoids,
Very
S-
good.
SLE,
Actually,
Very good.
fracture,
Very
fracture.
good.
mhm,
Yes, 4. We said 4.
yeah.
Therefore, very proud of you. And one more drug causes osteonecrosis of the jaw. Somebody missed it.
That's glucocorticoids, steroids.
And what else? One more
Oh,
drug.
oh,
Bisphosphonates.
Oh, yeah.
Okay. They also cause sometimes osteonecrosis. All right. That's very important for you to remember. Okay. So the patient has a history of depression and polymyalgia rheumatica. In polymyalgia rheumatica, how do you differentiate polymyalgia rheumatica with any other cause of with fibromyalgia?
in fibromyalgia, I think we have depression, psychiatric conditions. In polymyalgia rheumatica, we have proximal muscle weakness.
And
And
in
There's
we have
fibromyalgia,
polymyalgia.
we'll have tender points, I think.
What
In in
else?
in polymyalgia rheumatica, there is no muscle damage occur. In the CK level will be normal, but in the
And there's
fibromyalgia, the muscles involvement will be there.
and there's no weakness in polymyalgia rheumatica.
So the main difference to differentiate between polymyalgia rheumatica and fibromyalgia is the ESR. You monitor the ESR. In polymyalgia rheumatica, the ESR is high because it is an inflammatory condition. Okay, we also know that polymyalgia rheumatica is associated with giant cell temporal arteritis. We know that, right? Fibromyalgia, it is just a condition, it's a psychiatric condition where you feel that you have tender points all over the body and there is no pathology going on in the muscle. Okay, and that is why ESR is normal in fibromyalgia. That's an important thing. It is very high yield for you to remember. First, go check the ESR. Boom, you have the differentiation. Okay. Do not go through the lines. Oh, this is happening. Oh, this is not happening. See the ESR. If it is normal, fibromyalgia, raised, it is polymyalgia. Okay. So go through, try to remember that. Okay, so the patient appears to be in significant pain. She's unable to move the right hip and the right leg appears shorter than the left. A pelvic X-ray, we see that. What's happening in the X-ray? What happened?
Fracture of the neck of the femur.
Which neck of the femur? Right,
So
left?
right leg,
Right side.
right neck.
Yeah.
Yeah. Okay. So that's so what
Mhm.
injury of which of the following is most likely? So we talked about
Yeah.
osteonecrosis. Yeah.
The medial circumflex femoral artery. will be involved.
Exactly. Talked about that. I think I discussed this in the initial question. So I think we know that, right? So the femoral neck fractures, medial circumflex artery, femoral they ask, okay, and then obturator, very less likely they will ask you lateral circumflex. Okay, what does lateral circumflex femoral do?
Mm.
Supplies the head also, I think.
Yeah, so we know that a medial circumflex it kind of loops around with the lateral circumflex. We know that, right? Do we know that?
Yes.
Blood
Okay.
supply to the femoral head and the neck. Yeah.
Yeah. So we know that the medial circumflex, it kind of goes and it loops around and forms the lateral circumflex artery. I don't know where it's, if I'm missing it. Yeah. So at the back of the femur, you will see that it forms a lateral circumflex. Front, you will see that it forms a medial circumflex. Okay. So it is looping around the head of the femur. Okay. That I want you to remember. Okay. Question number 4. What's this? What's happening? So there is 41-year-old man. He's an avid bicyclist. Okay, increasing pain exacerbated by cycling or walking. Okay, he does not have recent trauma, and but he does have SLE. SLE, guys. On physical examination, the patient has a noticeable limb, decreased rotation of the right hip. Okay, what's happening? What's happening over here? What's wrong?
Avascular
Cross.
necrosis
Necrosis.
We
of
know
the
that.
right femoral head.
Yeah. What do you think the answer is?
Yeah, the answer will be the impaired blood supply to the femoral head.
Exactly. So we talked about the osteonecrosis or the avascular necrosis. We mentioned how steroids, head fractures, excessive alcohol use, sickle cell, SLE, they cause that. Other thing I want you to remember that bisphosphonates cause osteonecrosis of the jaw. So they don't cause of the osteonecrosis of the femur, but they cause bone necrosis. But they do cause bone necrosis of the femur as well, but more commonly they cause osteonecrosis of the jaw. That's an important adverse effects of bisphosphonates. Okay, and yeah, so we talked about that. We know what it is. We so there is. Do you guys have any questions for me over here? No. Okay. Yeah, so we go to the question number 5. Okay, so there is a 17-year-old boy. He has had a lower extremity injury. Because he was tackled roughly, he felt something snap in his right leg. He avoids bearing weight. Okay, he avoids bearing weight on the right foot. Examination shows a large contusion and tenderness over the right proximal fibula. If we see the X-ray, we will have a better idea what's happening. What's happening, guys?
Fibular head
Fracture.
fracture.
Exactly, fibular head fracture. Which of the following is impaired? What's happening? What artery supplies fibula and what does it, kind of
Co-
do? What's happening?
Common peroneal nerve get injured because it loops around the fibular head. When there is a fracture of the fibular head, the common peroneal nerve get injured, and it causes it divides into the superficial branch and deep branch. And the superficial branch have the sensory sensations over the dorsum of the foot, except the web space area for between the first and the second finger. So toe that will supplied by the deep branch. But
Mhm.
here is the sensations of the dorsum of the foot is the answer, right? See.
Exactly. So sensation of the dorsum of the foot, you need to remember the courses of it. That's very important. If we talk about the common fibula nerve, we will see that, it kind of loops around this. And okay, so I have a child. How do we differentiate fractures from soft tissue without an X-ray? How?
Sorry, what is the question?
The question is, how do we differentiate a fracture from a soft tissue without an X-ray or any radiographical findings?
The swelling
By,
and
by
Exactly.
Person won't be able to bear weight.
bearing weight, if he can bear a weight, that's tissue, and if can't bear a weight, that most likely fracture.
crepitus.
And what else? So in both conditions, what if I tell you that the people can bear weight, but it is a number of steps that's different? So usually in fractures, the person is in a lot of pain and they cannot move towards more than 2 steps. Okay, in soft tissue fractures, they can move more than 2 steps. Okay, in fractures, they cannot do that. There is something called the Ottawa's rule as well, but I think it's not important for step 1. It's more of a step 2 thing. So I won't explain to you in that in detail. But most of the times when they're referring to a fracture, it means that the patient cannot bear weight. Usually that is the only differentiation between a USMLE step 1, that fractures you cannot bear weight, soft tissues you can. But in terms of step 2, they have a same picture that they both can be able to bear weight, but it's a number of steps that's different. So it's not important for you to remember. It's just an additional information that I shared. You need to remember the nerves. What are they supplying? We know that peroneal, everts, and dorsiflexors, right? Okay. What does the tibialis posterior do? The tibial nerve or the tibial nerve. What's the function of that?
Inversion and
Foot
flank
inversion. Foot inversion.
Exactly. And what part of the foot does it provide the sensory supply?
Yeah, sole of the foot, tibial nerve one.
Very good. So we go to the next question. Physical examination shows tenderness in the L5 region, but no neurological defects are present. A spine X-ray reveals anterior displacement of L5 vertebra relative to the S1. Okay. The patient condition is most likely caused by the injury to which of the following? 14-year-old girl, low back pain. There is gymnastics. Because of her gymnastics, her pain is worse after training sessions. The patient reports no significant back trauma. Okay, Menarche was okay. What do you think is happening over here? It's anterior displacement. They gave it.
B.
Yes, there is the anterior displacement of the vertebral body and because of the fracture of the pars interarticularis.
Yeah. Mhm.
Because the vertebral body and the transverse posterior intervertebral disc, they don't cause the anterolisthesis of the vertebral body. But here is the anterior displacement. That means the fracture will be at the pars level.
So there are 2 words that they're asking you. First is spondylostasis, the other is spondylolysis, and the third word is spondylosis. Now these all are kind of hard to remember, because they talk about spondylosis, they talk about spondylolysis, they talk about spondylostasis. So it's different. Whenever they have thesis in the word, that means they're talking about something related to sensation, like paresthesia, right? Thesia. So whenever there's something thesis, that means they're talking about sensation. They're talking about a nerve that's getting probably involved. Okay, so that's there. So if you see that spondylolysis is basically the fracture of the pars intercularis. That this is the pars intercularis, and it has kind of broken from over here, and the forward slippage of the L5, the forward slippage of the vertebra is known as this spondylostasis, because then it kind of compresses the nerve. Okay, so spondylolisthesis is the forward slippage of the vertebra. Spondylolysis is the fracture. Lysis, which means bone lysis, bone breakage. Okay, easy way to remember for you. And spondylostasis, which means nerve is getting damaged. Why? Because the upper vertebra is slipping over the lower vertebra, and that is why the nerve is getting compressed. That condition is called as spondylolisthesis. All right. If you kind of go through that, we know that we have an idea what it is. Okay, so I don't think there is anything to explain over here. Okay. So I'll move on to the next question. Question number 7. All right. So there is this 72-year-old man comes to PCP with 6-month history of back pain and bilateral thigh pain that's provoked by walking. Okay. So he has pain when he walks, and when he leans in, relief. This is the answer. That what is the condition happening, guys?
Spinal stenosis.
Spinal stenosis.
Yes.
Very good.
Stenosis.
Yeah. Mhm.
Spinal stenosis is happening. And so on physical examination, muscular strength is normal, and the sensory findings are unremarkable. Peripheral pulses are full and symmetric. Thickening of which of the following ligament is most likely contributing? What do you think is happening?
Ligamentum flavum is
Ligamental
thickened.
flavum.
Ligamentum flavum.
Okay, yeah. So we know that this is a classic picture of lumbar spinal stenosis. Whenever a patient gets back pain, and it gets better when you relieve forward, when you kind of lean in forward, that's spinal stenosis on USMLE. Similar to like pericarditis, when a patient leans in forward, his pain gets better, he's able to breathe better. So it is the pericarditis of the bones. Okay, so it gets better when if you lean forward.
Yeah.
This
Mhm.
is a lumbar spinal stenosis. All right, we call it the pericarditis of the bones. So yeah, so this is the ligamentum flavum that I was talking about, that you guys talked about. So if we just kind of go through what this is, so this is not important. What I want you to remember, that this is the ligamentum flavum, and when it kind of gets hypertrophy, or it gets enlarged, then what happens? It compresses the spinal cord canal, and because the nerves that are passing through, they get compressed, and that is why it's called as lumbar spinal stenosis. All right, I just want you to remember that, and all of these words not important for you to remember. Okay, then we come to the next question. Okay, brachial plexus, I always hated it throughout my entire life, I don't know why. The Okay, so the left biceps and brachioradialis DTRs are normal, but the triceps reflex is diminished. Okay, right upper extremity sensation is normal. A lesion affecting which of the following labeled section the brachial plexus is most likely causing the patient's finding? Okay. Now, what are the findings? There is this patient who comes to the office due to pain in his left neck and shoulder area for the past several months. Okay. Numbness and weakness in the left hand. So left neck is involved, left shoulder, and left hand. Okay. And he went to multiple places, no relief came. So what's important is left upper extremity shows a decreased sensation in the palm and the index finger and middle finger. Okay, so they kind of told us that neck, shoulder, arm, and the middle finger, the index finger, and kind of like the lateral portion of the hand is getting affected. What do you think is
Median
happening?
nerve.
This is a median nerve pathology. Yeah.
It's a medial and radial as well.
Medial
Yes,
and radial both are getting involved here because the triceps reflex is also lost.
And,
yeah,
and yeah, it should be like a proximal lesion as it's involving two nerves.
very good. What do you think the answer is over here?
A.
I don't know this. I mean, I hate brachial plexus, so I'm clueless on this. It's you guys who are going to tell me what's this.
Yes,
Okay,
agree with the A because in the A option we have the radial and the median both.
yeah,
Radial nerve and the median nerve both are formed by the A trunk. Because the other options not the B, because in the B we have the axillary nerve and also the C option is not there because in the C option there is the ulnar nerve. So there is the involvement of the radial and median both.
yeah.
So it's not the D option and not the E option.
Very good.
Yes.
So if we kind of see this unfortunately you have to remember all of these nerves: musculocutaneous, axillary, radial, median, ulnar, very important nerve. Kind of figure it out from where these are the cords, anterior divisions, and then trunks, and then C5 to T1. That's the brachial plexus. Okay. What does C8 do? What does C8 do? Where is it going? Where is it going?
CA, your
Ulnar.
doctor?
Ulnar.
Very good. Where is the long thoracic nerve going to? What does it supply? Long thoracic.
Long
Serratus
thoracic
That
nerve,
anterior.
serratus
serratus
anterior.
anterior muscle.
Yeah, serratus anterior
Very
muscle.
good. Remember the salt mnemonic, serratus interior, long thoracic, salt mnemonic. So yeah, long thoracic nerve, they do ask as well, serratus anterior. When does serratus there is also a pathology, I think, for serrated winged scapula. I think
Winging
so.
of scapula, yeah.
Yes.
Yeah.
If I remember correctly.
During mastectomy, that this nerve is injured mostly and causes
Very
a
good.
winging of scapula. Yeah.
Exactly. So, okay, so we have the 73-year-old woman brought to the ED due to right hip pain. Okay, what has happened? What has happened over here? What's this? What's happened?
Greater trochanter injury, fracture of the greater trochanter.
Okay,
And the
and
involvement, they have asked the involvement of the muscle. So the gluteus
Gluteus medius is the
medius
muscle
muscle
which is
gets
attached
attached
on
over
it.
Immediate.
there.
Yeah.
So
very
that
good.
it,
So we know that this is the gluteus medius muscle that is attaching from the ilium to the greater trochanter, and it's important. They don't ask you usually muscles, but if you have free time, then you can kind of go through that. Okay, what is a Tredelenburg sign? What's a Tredelenburg sign?
uh, this sign
This is the
shows to
It is
differentiate
the
between the
displacement of the hip
weakness of the
on the
abduction. Yeah.
unaffected side.
Yeah. So you see when the pelvic drops when they're walking, sometimes they give you the
Yeah.
Tredelenburg sign on the exam and they ask you that, oh, what's happening over here? So you talk about that how the gluteus medius is getting involved. Okay. So this is important for you to remember. I think there's a table in first aid. There are all muscles present over there. Kind of go through them and just remember what they're doing, what their function is. Just remember what their function is, and that's it. They won't ask you anything more than that, and the associated vessels with it, such as what are the arteries, what are the nerves kind of associated with it. If they do have a important pathology, then kind of go through that. But yeah. Okay, so we have the 10th question on examination. There is bluish discoloration of the joint. Okay, he has maximal tenderness of the palpation at the anterolateral aspect of the ankle joint. Forced inversion of the foot also causes pain. Okay, so there's this 45-year-old man. He has come to us because he has twisted his ankle. He has a pain. What I think it's very, very, very easy. What's the answer, guys?
It's the talofibular ligament.
Talofibular ligament. Talofibular ligament, yeah.
They only ask you about one ligament in the leg. That's talofibular. That's it.
Yeah,
Memorize it.
forced inversion. Yeah, forced inversion always injure the talofibular ligament.
Exactly. So we have this patient, okay, and what's wrong with this patient is that there was this patient on examination of her right hand, decreased sensation in the palmar aspect of her first three digits, okay, first three digits. She fell on that. And there's decreased sensation in that, and a small bump is noted. Lunate dislocation causing median nerve is suspected. Which of the following mark bones is most likely dislocated? So they want you to identify lunate bone. Where is the lunate bone?
the
This is
D
D.
of
D. Hmm.
Yes,
pie,
the
pie shaped bone.
What is
Yeah.
this bone?
Hello?
What is this bone? What is A?
Trapezium.
Trapezium.
What is
Trapezium.
what is C?
C is the scaphoid.
Scaphoid. Yeah.
What is B?
Capitate
Capitate.
What is E?
is the
Scapoid.
pisiform. E is the
Pisiform. It is
pisiform.
not scaphoid, pisiform. Yeah.
Where is the triquetrum?
Triquetrum is in the
Behind the
yeah, pisiform.
in the
E is
pisiform, under the
Pisiform.
triquetrum.
pisiform.
Around.
Mm.
Very good. Okay. So we know that the answer is D over here, right? We'll put it, we'll see if we're right or wrong. And we were, yeah, so we know that these are the bones. If you kind of want me to go through them, like I already went through. So this is a scaphoid, this is the lunate, and then we have the pisiform, triquetrum is behind it. This is the hook of the hamate, or the hamate bone. This is the capitate, and then trapezoid, then we have trapezium. So I remember this mnemonic. I don't know how many of you remember. She looks too pretty, try to catch her. I don't know if you went through this mnemonic.
Yes,
I remembered it.
yes,
So,
I remember.
so there is this. Okay, another question. Avid golfer. Okay. thickening and calcification of the supraspinatus tendon, which of the following arm movements, when performed against resistance, most likely to provoke?
Abduction. Yeah, abduction. This is the
Abduction.
rotator cuff injury. Abduction.
How many muscles does rotator cuff have?
Supraspinatus, infraspinatus, teres minor, and subscapularis.
Yeah. So yeah, so that I want you to remember. I want you to remember we call them the sits muscle. Remember the function of them. Remember the innervation, the supracapsular nerve, axillary nerve, and then the upper and lower subcapsular nerve. Sits muscles are very important in rotator cuff injuries. So that I want you to remember. And yeah, memorization question. Memorize it. Unfortunately, no other way to kind of go through this. Okay. Then we have this 54-year-old woman, right upper arm weakness, and oh, I think this is that what I said. Yes, what's happening, guys?
Winging of scapula, I think.
Yeah. Long thoracic nerve is injured.
Nerve.
What do you think the answer is?
It's
Yeah.
C.
C is a
Mastectomy
mastectomy.
with axillary lymph node
Long
axillary
thoracic
lymph
nerve
node.
So
involvement,
we
yes.
talked about how if the serratus anterior gets injured, we call it the winging of the scapula, and it occurs in people who are having mastectomy. So that's there. Okay, we went through this concept, so I'm not gonna go through this again. Okay, 14th question. The patient is taking apixaban for chronic anticoagulation therapy. Physical examination, the right patellar reflex is decreased compared to the left. Okay, what's happening? What's happening in here?
Here on the CT scan, there is the hematoma formation on the right side, and the over the iliopsoas area, retroperitoneal hematoma. So that is getting the involvement of the femoral nerve. And they have asked which of the following additional finding is most likely to be seen in this patient. So because of the femoral nerve involvement,
It
we
causes
have
loss of
the
sensation on the
soft
anterior aspect
sensation.
of thigh, of right thigh.
Yeah, so we talked about that femoral neuropathy. We know that when this femoral nerve gets affected, it causes the formation of the hematoma, and decreased patellar reflex was a very big giveaway for them. When they
Yes.
about patellar reflex, it's a very big giveaway.
Mhm.
Patellar reflex, what nerves supply patellar reflex? I know it's the sciatic plexus, lumbosacral plexus. What?
L5,
L4.
L4, L5,
L4, L4
L5.
for the patellar and the S1 for the sciatic.
Very good. What does S2, S4 do?
S2, S4 supply the pudendal nerve that supply the perineal area.
Not the femoral area.
S2, S4, the perineal area. Very good. During gynecological injuries, we do have problematic S2, S4. S2, S4 gets injured in a lot of obstetric injuries or gynecological injuries because it supplies the perineal area. Very good. Okay. Then we come to the next question, 15th. Okay, what's happening in this? What's happening?
They have asked the
This is
arrow.
It
is the psoas muscle.
Psoas muscle, yeah.
Right psoas muscle.
Yeah. So we see that there is a 52-year-old man, weight pain, abdominal pain, fever, anorexia, weight loss, HIV. CT scan reveals an infection with the structure by an arrow. So, okay,
This is
there's
psoas abscess, yeah.
psoas abscess is also associated with another condition. What's that?
TB.
Diabetes mellitus.
Yeah,
So
that's
diabetes
TB.
mellitus patients or even autoimmune patients are, they have psoas abscesses. They usually present with flank pain, a lot of flank pain, weight loss, and yeah. So, see that. This is the they're talking about the psoas abscess over here. So remember that see, I told you that they have flank pain, fever, inguinal mass, usually HIV. Oh, diabetes is mentioned over here. See, I
Yeah.
was talking about
Yeah.
how it is important. I remember it 1.5 years ago. I gave STEM 1. So yeah, go through that. They ask you in context of diabetes mellitus as well. So try to remember that as well. Okay, we have the 16th question. Okay. Physical examination is negative for local erythema and swelling, and the patient has full strength against resistance on knee flexion and ankle plantar flexion bilaterally. Walk across the room. It's dropping every time he raises his left foot. What do you think happened?
Trendelenburg test is positive. And
Which
just
Mhm.
because of the involvement of the gluteal medius muscle and the
Mhm.
injection at the wrong site, that's the supromedial quadrant of the buttock.
Mhm.
Exactly. So we talked about the Trendelenburg sign, how it involves the gluteus medius, and how we know it's because of the injury to the superior gluteal nerve. That's if you kind of give the injection over the superior medial quadrant, then it's getting affected. Okay, I want to know, what does gluteus minimus get supplied by? Gluteus minimus.
Applied by
Superior
the
glutes.
The
superior
inferior.
Yeah,
gluteal
superior
nerve.
glutes.
Okay, what about gluteus maximus?
Maximus is supplied by inferior gluteal nerve, by the medius, and minimus both by the superior
Very good. They
gluteal nerve.
kind of go opposite. So gluteus maximus is inferior gluteal, and gluteus medius is superior gluteal. So they go kind of opposite. Okay, 17th question. 32-year-old male presents to the ER, sudden onset heart palpitations, blood pressure, heart rate 160, regular rhythm, to do Valsalva to relieve these symptoms. What's happening? Sudden onset heart palpitations.
Mhm.
What's happening?
Supraventricular tachycardia, SVT.
PE.
What's
A
this?
they have asked the
They're asking about
Valsalva
that.
maneuver, which
Mhm.
muscle is involved. So
Yeah.
the abdominal
The
muscle is the abdominal
yes, yeah.
muscle, which is the rectus
Okay.
abdominis muscle.
Rectus
That is the
abdominis is
A.
mainly involved, and the answer is A. Yes.
Answer is A.
Very good. What is the muscle? I want to know. Okay. What is B?
This is the iliacus muscle.
B is the iliacus.
Yes.
Yes. So sometimes, even when we don't know the answer, use your brains, and it kind of tells
Mhm.
us
Mhm.
answer.
Mhm.
So we know that there's paroxysmal supraventricular tachycardia. It got happened, and we kind of tell them to do Valsalva, or you kind of rub their neck, and that is how they get sometimes terminated. The rectus abdominis muscle, it is important for Valsalva, and we know that the A was rectus abdominis. Okay, we talked about how B, it is the iliacus muscle. C over here, it is the gluteus minimus. Okay, this is the gluteus medius. And what is this? What?
Maximus.
Very
E
good.
is
Gluteus
the
maximus.
maximus. Yeah.
Very good. Okay, 18th. Okay, there is a soccer player evaluated for difficulty ambulating and right thigh pain. He has no other medical conditions and takes no medications. On examination, there is weakness with hip flexion and knee extension. Which of the muscle is injured?
Hamstrings. Hamstrings involved in the hip
Yeah,
flexion
rectus
and the
formis. Yeah.
extension. So the hamstrings includes the biceps femoris, semitendinous, semimembranous, and the in the option here
Rectus
is the
femoris. Yeah.
biceps femoris long head. A will be the option.
Yes.
What does it was rectus femoris? So why
Mhm.
is it rectus femoris? Can anybody tell me?
Because
Hip
it
tension
causes
is caused
the
by
flexion of the hip and extension of the knee upon. Yeah.
yes. So it's
Yeah.
not the hamstring.
So rectus femoris, iliopsoas, and sartorius are the major hip flexors. We know that out of them, the rectus femoris and sartorius are affecting the knee movement, and sartorius, it flexes the knee, while the rectus femoris, it extends the knee. Okay, what are the, so we know that whatever the hip flexors are, they are extensors at the knee, and vice versa, right? We know that. So what are the hip extensors?
Hamstrings.
Hamstring muscles. Hamstring muscles.
Exactly. So hip extensors are your
Hamstring.
hamstring muscles, which will be flexors of the knee.
Yes.
Okay.
Yeah, these are hamstrings. Yeah. Mhm.
Hamstrings are the extensors. Yes, yes.
Hip extension and knee flexion. Yeah.
Exactly. So they will, if they will do extension at the hip, they will do flexion at the knee, and vice versa. Okay. So we have the third last question. Several are okay. So there is this patient who came with a right leg injury, unable to bear weight, fractures in the tibia and the fibular shaft. Patient undergoes close reduction immobilization. Oh, severe pain in the right leg. I talked about this in my lectures. If you guys remember what's happening.
Yeah,
It's the
compartment
acute
syndrome.
compartment syndrome. Yeah.
Yeah, and what is the treatment of that? How do we treat compartment syndrome?
Fasciotomy.
So we
Osteotomy.
Fasciotomy. Yeah.
How do we diagnose it?
Severe excruciating
it's
pain.
So
5
the
P's.
parallel
Big
Out of proportion pain.
Exactly. Good.
parallel
Pain,
pain and the poikilosis. Yeah.
pallor, pulseless,
Pulseless pain. Paresthesia.
like it's 5 P's.
Exactly.
Yeah.
Yes. So we measure the compartment pressures, and when we see that the compartment pressures are really high, then we kind of take them to do fasciotomy and kind of decrease the pressure. Compartment syndrome, it can be found in fractures, it can be found in burn injuries, it can be found in patients who are overly, if you give a lot of fluids to the patient, that's going to happen. So that's usually the compartment syndrome causes. Okay. Now it talks about the anterior compartment of the leg. All right. Which of the things is supplying the anterior compartment of the leg?
Deep peroneal nerve.
Anterior
Deep.
tibial
Deep,
artery, deep peroneal nerve. Yeah.
peroneal nerve and anterior tibial artery.
Okay, so it's the peroneal nerve. So is it C or is it E?
A, deep.
A, deep peroneal nerve.
Sorry, I
Yeah.
didn't see that. Yeah, A.
Superficial is lateral compartment.
Very good. What about the great saphenous vein? Where do you find that?
Medial side of leg.
Very good. And that is sometimes also used to take, used in coronary bypass surgeries. That is why. So, yeah, we know that they were talking about acute compartment syndrome. It can be due to fractures, thermal injuries, like I mentioned, burns, non-traumatic causes is if you have a lot of bleeding. Early diagnosis, you do surgical decompression. Like I said, you do fasciotomy, involved compartments. Otherwise, it can cause nerve damage, or it can cause necrosis. So we know that most common side of ACS is the anterior compartment, which includes the foot extensor muscles. Anterior tibial artery is over there, and deep peroneal
Peroneal
nerve.
nerve.
So remember that each compartment is very important for you to remember. Lateral compartment of the leg has the superficial, yes, and proximal part of the deep peroneal nerve. Again, kind of memorization based thing. Just remember it. Just try to memorize it. Unfortunately, no concept behind it. Okay. 34-year-old woman comes to the office due to fatigue. She lives alone and works as an accountant. Patient has no chronic medical condition, does not use tobacco or alcohol. Blood pressure is really high. During physical examination, the patient sits up from the supine position without using her hands. Which of the following muscles contributes to the described movement? Yeah. What do you think the answer is?
Rectus abdominis muscles are used,
Sauce muscle.
and the hip
Sauce muscle.
flexors. The answer is the psoas major muscle. Yeah.
Yes, was.
So everybody agrees with psoas?
Yes.
Okay. Let's see if it's right. Yeah. So again, very root-based memorization. Memorize it. Unfortunately, no concept behind it. Memorize it. Okay.
Doctor, is it important to memorize all of it, like abductors, adductors of the leg?
Unfortunately, yes. They can ask you
Oh,
any muscle and say that what's I know it's very hassle-some, and that is why I memorized these muscles just one day before my exam because I was forgetting it. So that is why I memorized this one day before my exam. I was forgetting it again and again. Kind of just go get a mnemonic or something to help you remember. Dr. Ahmed can help you with that. He is really good at mnemonics, so he can help you with kind of a shortcut for you to remember all of this. The nerves are very, even if you try not to remember, just if you don't remember this, try to remember the innervations. Okay, these are very, very important. Innervations are very important for you to go through, and unfortunately these muscles are kind of important for you to remember.
so doctor, this is high yield. I mean, they're gonna appear in exams.
This is not high yield, but they do ask 2 to 3 questions of this. Okay.
2 to 3 questions.
Yeah, they do ask you.
Dr. Maheen, like, sorry to interrupt you. So that MSK from Mahalman PDF is good enough, or we should still supplement it with first aid?
Supplemented with first aid.
Okay, thank you.
Yeah. Okay. So, 44. So 44-year-old woman, increasing right hip pain, exacerbated by walking and by sitting. With the right leg, see, this was, I think I mentioned this in the first question also. Obese woman, pain, in the sitting with the right leg crossed over the left leg, has had a history of plantar fasciitis and internal rotation. So examination, right hip abduction and internal rotation against resistance. When the hip is flexed, it reproduces the pain. Okay. The cause of the patient's symptoms is suspected to be pathology at a tendon insertion. What is happening? What's happening, guys?
Abductor tendon, the tendon insertion site is means the um, avulsion fracture of the tendon of the gluteus medius muscle, because
Yeah.
it is the abductor. It is the
Yeah.
abductor and the internal
Gluteus
rotator,
medius and gluteus
and
minimus
they are suspecting
tendons
the
are.
pathology at the tendon insertion site. So it might be because of the greater trochanter fracture or some kind of
Because of
avulsion
osteoarthritis.
fracture,
Yeah.
avulsion fracture at the and the involvement of the gluteus medius muscle because of the abduction,
Hmm.
and it is the obese patient too. I think
So
it's a B. Mhm.
it's the B. We all
Yeah.
agree?
Yes.
Okay. Yeah. Again, unfortunate, but you have to remember this. Do not remember, they don't ask you the origin insertion. It's not high yield. I won't recommend you to, it's almost non-existent in the USMLE. They never ask you this. But again, UWorld is a very big question bank. People also use it for their shelf exams. American medical graduates, they will agree with me that they use it to prepare for the shelf exams and a lot of other internal mock evaluations that they have. It does not come on the exam. It's very non-existent. They will ask you origin and insertion, not high yield. If you want to skip this, skip this. But try to remember the muscles in each compartment and their innervation. That's very high yield for you to remember. And I think we are done for the day. Yes, if somebody wants to ask questions, we have 2 to 3 minutes, and then Dr. Ahmed's session will start.
Hello, can I ask?
Yeah, sure.
Yeah, can I get a recording for this UO explanation? This one and the previous day?
Yeah, so the previous recording is available on the group. I think Dr. Hamza and Dr. Laiba, they shared them.
Is it in the Discord only?
I think Dr. Ahmed, are you here?
Yes, I'm here. So you can just search in the group. We have shared all the recordings, and right after this session, this recording is also going to be shared.
Because we didn't see in the WhatsApp, it's only in the Discord.
No, we have shared in the WhatsApp, so you can just contact Dr. Hamza. He'll just guide you.
Okay, thank you.
Okay, guys, I think that's it for today. But I'm like really disappointed with your feedback, Dr. Ahmed. I'm very disappointed with the feedback.
What happened?
I gave them task to do Fanconi's anemia and Beckwith anemia. I wanted them to go through that, and only just 1% to 2% participates in my class. 2 to 3 people participate, and they did not even kind of go through that topic. Only 1% went through that topic. What is the use if we are having around 40 to 50 students in our class, and only 1 to 2% is kind of actively involving themselves, and only they are going to give step one and not the rest of the people?
Okay, so it's like
Yeah, actually, yeah, I heard you. Actually, we are working in the morning, so I was in the hospital, so I heard you. But yeah, I already there are some people working, so we just listen sometimes and we don't participate. But we are
okay.
some of us it's
What we
full time workers.
so
Yeah.
hello. Yeah, so like I would say that there are no excuse for if your mentors just give you a task, you have to do that because if you are working hard, so you guys should also put in your efforts, right? So it's okay, Dr. Maheen. Like they have one more day. So tomorrow, Dr. Maheen, first of all, you are gonna look for if they have done the task or not. Then we are gonna start the session,
No,
right?
I have not given them any more tasks. I will not be giving them any tasks because whenever task I give, they don't work on that. 2 days ago, even 4 days ago, I gave them the task. They did not do it the next day when I asked them. This is the third day I have to ask them again. So even this is the third time that's happening. So I won't be giving them any task. Dr. Laiba, Dr. Hamza, they will be giving
Although you
task.
you should go for the task. I'm just telling you they'll do that. Can you just guys tell me what happened? Why you guys can't complete the task? Is there any explanation for that? Any issue that we can just solve? Hello. Please turn on your mic, Dr. Amna, Dr. Abida, Dr. Arsh, Dr.
Sorry, doctor, we forgot.
Hello. You guys forgot, right? Hello.
Yeah,
Yeah,
yeah.
it's
Actually,
no, no. I
he's
agree with
like
Dr. Shafiq. Dr. Shafiq is an active member of our class. I don't have any complaints with him, but I do have complaints with the 40 people who are, sit. I see only 4 to 5 people, kind of participating in my class, and that's it. And they're always participating, like they have to go and give the exam. Rest 55 people, I don't know why I'm teaching, because if you're not here to bank on and cash on, we are putting our efforts to help you guys succeed. That is what I said on day one. There is nothing in for me, Dr. Ahmad, Dr. Hamza. It is for your own betterment. If you're not going to do the task, it popped up in my exam, guys. That question came in my exam, and that is why I want you to have the concept of that. Okay, and if I am saying something is coming on the exams, and that means it is coming on the exams. It is very high yield for you to go through that. If you go and not ace your USMLEs, then you're going to come back to us and say that, oh, you did not tell me, right? So
What's the problem? Hello. Can you guys just please tell me what's the problem? Why aren't you guys just doing the tasks? As I have already told you,
Dr. Ahmed, I struggle with is active participation, engagement from the participants. Only 4 to 5 people, and I know their names by heart. They participate. The rest of them are just sitting. I don't know if they're doing their rest of the work or whatever. They're driving, or they're just listening like ghost. No, you need to say that if you understand the concept or not. Or I ask them again and again, what's the concept? What's the concept? Does anybody have an answer? Does anybody else want to explain the concept? And I hear no review. So then I move forward.
I totally agree.
Doctor, can I speak? I think
Yeah.
I think because you ask and then we don't put up our hands, because we just left from our group and everybody in the group, we had done these questions and they are very knowledgeable on it. I think when you just ask and then somebody engage, then the rest just stay. We do participate. Like me, I did the Fonkanu, but when you ask and somebody was explaining, then we stayed quiet. It doesn't mean that we did not do it. Like as I said, in our group that we did, we just left there and came here. We did nearly all of those questions. And there are people there who are so knowledgeable on it, but they could not participate because when you ask and somebody engage, and then the rest just stay.
No, no, even after that, whenever they answer, you answer after them, even if they have told me. Okay?
Okay, listen.
So we do not know that.
Hello? Okay, so it means that you guys have already done the task, right? So it means there is no need of doing it, right?
No, no, that's not
Sir,
what I
it's
meant,
very
doctor. No.
beneficial. We requested Dr. Maheen because so many people have went through those questions, but still we want a revision because it's like repetition. How much time you repeat, it's better for us. So we are really thankful for you and Dr. Maheen. You guys are doing great, and we are sorry about the assignment. Yes, it just went out of our mind. And we were just focusing on UWORLD questions, and sorry, we will take it serious next time.
Let me just mention one thing, please, right? I did last marathon, and like 80 to 90% of students complain of a single thing. Even when I was just starting the class, Dr. Amna, you just told me that it's very difficult for us to like keep things in the mind and memorize, right? So for that, we have Dr. Maheen came, and she want to do repetition kind of thing again and again. You guys have to participate. Believe me, on your exam day, this discussion is going to help you. No Ankis are going to help you. No passive reading is going to help you. No like reading MCQ from UWorld is going to help you. The things which you guys discuss here, which you say by your own mouth here, and just tell Dr. Maheen that this is the answer and do active participation, that is going to help you. If you guys are thinking like, please, on the first day I just told you that this community is for those individuals who want to like pass this exam, because we by ourselves do not want you guys to come back again for the next marathon and like keep on pushing your exam day to the end, and like that. These things are like not acceptable. Simply that like these things aren't acceptable. So if Dr. Maheen is just giving you tasks, just please take it serious. Go write it down on write it down on your desk that this is my task, and tomorrow before going to the class, Dr. Maheen, what you are going to do, you are going to open the names, and just you have to call their name. Like if this discussion even goes to 2 to 3 hours from tomorrow onward, I won't compromise on that, right? I'll be sitting here, I'll be calling each one name, and you guys are going to open your mic. You guys are going to participate on 3 calls. If you guys aren't participating, and if you do not have specific reasons that why aren't you participating in the discussion class, so we would not compromise on that, right? We'll just finish out your we will just remove you from the groups.
Other thing that I want to say, that we take your feedback very seriously, guys, because you have been a part of us. Whenever you reach out to me, Dr. Hamza, Dr. Laiba, we try to erase your queries. We try to answer them. We're even doing a research webinar because a lot of students asked us about research and they wanted to start it. So we take your feedback so seriously that we're, kind of investing our day and night into collecting the research team, me, Dr. Ahmad, Dr. Hamza. We are working day and night for the research webinar that we are going to be having on Sunday, so that you guys can be taking advantage of that. We have invited 2 of the great researchers for that. Contacting them, it's very hard because of their busy schedules. They're in United States Mayo Clinic, and because of that, it's very hard for them to kind of grab them and bring them. And we are doing that. Just why? It's not for our personal gain. We're doing it because we want you to succeed, so that you can have a great application profile for your upcoming math cycle. And when we see that these initial things get disregarded, to which we don't disregard any message, any literally even one message out of 500 chats, we will reply to you even that message as well. And when I see that I have 60 students, only 4 to 5 students are participating, imagine how disheartening it will be for me as a mentor. Okay, so try to actively participate. Even if you don't know, just say, open your mic and say, I don't know. Okay, but after those 15 to 16 questions that we are doing, from that, at least one question you will know, right? So if I see anybody else speaking, I will automatically tell the other person who've spoken 4 to 5 times to just stop speaking so that the other person speaks. But when I hear nobody speaking, then that person should also, it makes sense if they're speaking, right? So that's what I wanted to say. And yes, Dr. Ramesh, I see your hand raised.
Yeah, doctor. So, all I would say that these discussions actually really nice because, as Dr. Ahmed told, because whatever, like how much we read from fasted and all those evil, but these discussions are actually helps to drill those concepts in our brain, and this helps to in long term memory. So, yeah, these discussions are really nice, and also like as Dr. Margaret told, because sometimes like out not to just create chaos. So sometimes if like if you are asking anything and if any students are like responding, so other people try to like not to respond just to not to create any chaos. So yeah, like maybe if you can do that, like if anyone have to answer, they will raise the hand, then that will help everyone to participate, I think.
Dr.
Yeah,
Miss, I have
That will be helpful.
even if they're not able to raise a hand, they can put it in the chat box. Okay,
Yeah,
I've
yeah.
even memorized those names who come in the chat box. Okay, because I do see them when I have my screen on. I'm unable to see the screen, right? And that is why I say anybody can unmute and answer. But when I stop sharing my screen, then I go through the chat box and see who has answered. All right. So I do see that. So if somebody cannot answer, they can type in the chat box because I do monitor that as well.
Hello.
Yes,
So
yes,
I
yes.
have like an alternate for that. Like in the upcoming session, I'll just tell my team to have like a proper kind of presentation. We'll be seeing the chatbot on the side. But from tomorrow onwards, I'm thinking of I'll be sitting in the session and I'll be calling you guys by name, right? So from tomorrow onwards, like each and every one guys should be mentally prepared that they're gonna open their mic and participate in the discussion. Because if you are just it's not about that I'll just come here for 1 hour and I'll just leave because of my no, it isn't like that. Dr. Remis already know that, right? In the first marathon, when there weren't any people, like it's a big disrespect for your mentors, right? I would
Yes,
say.
yes, we know about the total history, and we were there. So
Yes,
yes,
like
but mhm.
if we have like 150 students, or and in the class we have 67 students, when you guys just quit the class, so there are 5 to 7 people still remaining, and like they're just sitting. They aren't. I think they just join the link and just doing their work. So please, if you can just take out 2 to 3 hours or like from your day, as I promise, right? And like these tasks just take 2 to 3 hours, right? I'm here for 1 hour, Dr. Maheen is here for 1 hour. If you guys like like we all are mature doctors, right? So we expect a kind of a good environment. You should just give chance to your other mates, call their name, please participate. Like you guys know your like each other as well, like in the Discord server. You guys just do your you know each and everyone. Like as Dr. Margaret is saying that everyone is knowledgeable, we respect that. We also know everyone is knowledgeable, but if we are just introducing a system to you guys for that is discussion, so it means that we are doing it for some reason, right? We know we know it will help you on your exam day. That was all. I think we are just kind of compromising our lecture time, so let's have 5 minutes of break and see you in my session, right? So you can just take 5 minutes of break, and from tomorrow onwards I'll be just sitting here and I'll be calling you guys name, right? And you are going to participate. Okay, see you after 5 minutes.
Thank you, Dr. Ahmed. Thank you, Dr. Mahim. I have something to say. I appreciate all that you guys are giving to us. And I'm in line with Margaret and Ramsey. And I also say, Dr. Mahim, that shouldn't stop you from giving us more assignments. We appreciate that. We know you guys are working it, doing everything for our own good. So please, we apologize on behalf of that. We would like you to continue to give us more assignments. It is for our own good. Thank you.
Yes, doctor.
Thank you, guys. Thank
And
you.
as regard the two assignments, already I prepared the answers and everything. But yeah,
Yeah. No,
but
it's
I was at work when you asked the question, so I was thinking somebody can answer. But I
no,
am
no.
ready when you come back,
I
Doc.
I see you in my lecture. I don't have a problem with you. I see you. I see I see Ramesh, you, Margaret, Rebecca, Monisha. So I remembered the names because they participate. So yeah. But I'll see you guys tomorrow. 5 minutes break, and then Dr. Ahmed's session will start. Good luck. Have a good day. Okay, bye
We
bye.
love you so much. Don't leave us. Thank you.
Okay, awesome. Okay, bye,
Thanks,
guys.
doctors. Yes, yes. Thanks for understanding.
Bye, guys. I'll see you tomorrow.